afternoon. It's my honor to be here today as a panelist on COVID-19 and HIV on the topic of disruption of HIV prevention services during COVID response in Bangkok. I'm Dr. Thanyawee Puthanakit. I'm pediatric infectious disease in tertiary care at King Chulalongkorn Memorial Hospital in Bangkok. I would like to share my perspective from the pediatric infectious disease specialists who are running pediatric adolescent HIV programs. But in the case of COVID situation, I also work as a team member at the Thai Red Cross Emerging Infectious Disease Clinical Center, which our hospital is a center of screening, diagnosis, and treatment of COVID-19 patients. So I would like to start with a brief summary of the COVID-19 situation in Thailand. Thailand has a population of 69 million population. So far, we've done quite a good job in COVID-19 control. We have about 3,500 confirmed cases over the period of COVID situation. For the timeline, we are the first country who have a first case of COVID confirmed outside Wuhan in earlier January. So we are start to have a policy and also a services for COVID screening. And in our hospital, we have a first case in the 9th of March. And you can see from the right-hand side on the graph of number of patients that come into our clinics. In total, we screen almost 10,000 people who are seeking care for HIV, for COVID screening. And also we have 197 confirmed cases in our centers with only one HIV co-infection. However, in that period of March to May, we experienced lockdown in Bangkok, which is the epicenter of COVID-19 in Thailand. So how we respond? The first thing we do is that we come as a team and discuss about what is the essential pediatric HIV services that we should maintain or modify during the lockdown. You can see from the slide is that in terms of prevention of mother-to-child transmission, we rely on service at delivery room and antenatal care because it's the emergency, so the services continue. However, they are apply physical distancing policy and also limit number of new cases for antenatal care. In terms of antiretroviral clinics, we need to modify the service to make sure that they are reduced in-person visits because of the capacity and the physical distancing and also lockdown. So we deliver antiretroviral drug supply to the patients via courier. And luckily, we be able to expand the drug supply from every 3 months to 6 months to maintain the drug supply to the clients. However, for PrEP clinic, the prevention clinic was considered as a lower priority. And also in terms of drug stock was shifted to supply for the patients who are living with HIV. So we suspend the clinic, in-person clinic. And because of the PrEP clinic have to have HIV testing before we prescribe medicine. So basically it's like PrEP clinic was suspended for a few months during the COVID lockdown and also in the situation in early on when we don't know what's going to happen, how long we're going to need to maintain the mobile phone contact or telehealth. And also in terms of client or patient's perspective, because the pregnant women and also people living with HIV was considered as a high risk of COVID severity. And also King Chulalongkorn Memorial Hospital was a tertiary care for COVID. So participant was reluctant to come to hospital to get treatment or prevention services. So we decided to do outreach programs. What did we do? We do HIV treatment program, like mentioned, that we deliver ARV to patients living with HIV. And while we're talking to them, we learned that they have some emergency in terms of economic problems because of loss of the job. So we set up emergency donation programs to support about 60 families with economic problems. And this is the nice photo that the kids sent back to us for appreciation of the help that we set up. And meanwhile, while we are trying to stabilize our pediatric and adolescent treatment programs, we also need to allocate staff to join COVID response team at the emerging infectious disease clinic, or we taking care of the patient at so-called hospital, which is the unit outside hospital at the hotel to be a unit to serve the patients who have mild symptoms when we have overload of patients in the hospital. And we also lend the support from our mental health team that experience with dealing with stigma discrimination of HIV to help the COVID team. And then we realized that we are lack of prevention of service in our hospital. This is examples of a couple of cases. The first one is in pregnant women, 33 years old, on her fourth pregnancy. On her first marriage, she has 3 kids without any problems. In her second marriage, she just married for 4 years and moved from province house to Bangkok. And when she aware of pregnancy in the midst of COVID-19, she don't know how to access to antenatal care. So she presented on when she was in labor in 16th of August at our hospital. And at that time, rapid test was positive. And she was normal delivered. A baby was 37 weeks and 2,400 grams. So in this case, we complete 4 weeks of neonatal prophylaxis regimen. And luckily, HIV DNA PCR at birth and 1 month still negative. But we need to see whether she would save from HIV. And this case wouldn't happen if she was pregnant during a regular situation. She can access to antenatal care. The second case is adolescent, 19 years old, MSM. He was in our care in June last year. He come for access for HIV testing and was start PrEP. He had a very good adherence. And her last visit with us in December, he had a regular follow-up, taking dairy PrEP properly. He had high level of TFVDP showing that he had good adherence and had refilled PrEP for 3 months. In April, our staff take a phone call and asked him to come to clinic to get the supply and also anti-HIV testing, but he denied because of the concern of COVID risk acquisition at our hospital. So in August, he contacted us to get a reappointment to the PrEP clinic to refill his PrEP. But sadly, his anti-HIV turned positive and he started ART treatment. So this one shouldn't happen if we have continuity of prevention services. And another group of youth living with HIV that usually they do performing quite well in our clinic. However, in this situation, they are vulnerable of life stress events and not know what to do. Some of them lost jobs, some of them out of school because they need to relocation to provincial area, which is more affordable comparing to Bangkok. So they have increased mental health issue. Many of them need to see psychiatrists or start antidepressant. And also with all of psychosocial aspects, it's affected their adherence and their loss of biological control and at risk of spreading HIV in the community. So what I learned from the pediatric adolescent HIV program standpoint during COVID situation, we need to have a better strategic plan of what to do during COVID situation. In terms of service plan for ARV clinic or plan for people living with HIV, it's much easier because you have defined population. You have a database of people you need to reach out. And also the medical supply can be reimbursed because they register to the national programs. In terms of staff location of prevention program, because we are so busy, secure pediatric ARV clinics and also shift some of staff to COVID response team. We should better to do more on the task shifting, recruiting more people to handle HIV prevention programs, such as case manager or peer group to make sure that we reach out to the patient at risk of HIV and encourage them to be continue to pick up medicine or come for HIV testing as soon as possible. Because in general, prevention work was faced as lower priority from the service delivery standpoint and also lower priority from the client's engagement standpoint. But also, we also have positive aspects that we learned from COVID situation on HIV prevention service. The first one is emphasize the importance of database of adolescent at risk that come into prevention service, either come for HIV testing or PrEP service, that we can reach out to them as quickly as possible in the situation of emergency or the situation that we need to close clinic, the face-to-face in-person clinic at a hospital. We should expand platform on telehealth and health or online counseling to maintain HIV prevention service. And also we can stratify patients who have good adherence to PrEP, similar to the case example, that we can modify service towards less in-person clinics, such as providing HIV self-test and also refill for the PrEP user who have good adherence, similar to the way that we refill ARV for people living with HIV. So in summary, we learned a lot about how to respond in HIV program delivery standpoint, especially in prevention, that we need to be more assertive and also to maintain and prevent HIV transmission. Even during COVID situation, that we need to reallocate staff or prioritize to make sure that HIV prevention service, especially for vulnerable adolescents who had less capability to navigate healthcare services or less motivation, to make sure that they still be able to get proper services and stay negative. Thank you.